it's this scandal of premature mortality because there's actually, as a result of those things, a 15 to 20 year reduced life expectancy gap for people who live with a severe mental illness. That's just an example of, if you have a mental illness, we'll treat you for your symptoms and we won't think about what's happening in the rest of the body. For prescribing medication, we also have this responsibility to make sure that there's a better management of their physical health right from the start.
But it's about finding the most personalized and personally sticky and sustainable way for them, and working with the client or patient to find what is the way to get you moving more that's going to be sustainable, work the best, intrinsically enjoyable in the moment for you.
And so I put some music on, and as the clinician, just started acting like a bit of a clown and started dancing. And she found that very funny, not because my dance moves were bad or anything. They're really good. It's just she was surprised, I think, more than anything.
Of course not. Hello, everyone, and welcome back to the Mental Wellbeing College. Today, we are joined by Dr. Oscar Lederman to discuss the benefits of exercise for severe mental illness. Oscar is a lecturer in the Master of Clinical Exercise Physiology program at the University of Technology, Sydney. He's a Senior Accredited Exercise Physiologist with over 10 years' experience working with individuals with mental illnesses. He's a mental health first aid instructor and is the lead author on the consensus statement on the role of accredited exercise physiologists within the treatment of mental health disorders. In today's episode, we discuss why people with major depressive disorder, bipolar, and schizophrenia are expected to live 15 years less than the general population, the importance of exercise when taking medication for severe mental illnesses, why so many doctors and psychologists are choosing not to prescribe exercise, and much, much more. If today's episode of the Mental Wellbeing College or any of the previous episodes of the Mental Wellbeing College has brought value to your life, I would be super grateful if you were to hit subscribe, follow, or to share this episode with someone you care about. We are on a mission to provide a free, accessible resource based on evidence-based wellbeing strategies to people the world over, and you subscribing, following, and or sharing helps us to spread the good word. Thanks so much for tuning in, and now to today's episode. Before we dive into today's episode of the Mental Wellbeing College, an important disclaimer. We do dive into the weeds of mental health, which means that at times we discuss sensitive topics like suicide, self-harm, and substance abuse. If hearing such discussion does bring up distress for you, please do seek the psychological and professional treatment that you need. The content covered in this episode is not intended as a substitute for professional mental health treatment. Dr. Oscar Lederman, welcome to the Mental Wellbeing College.
Thanks very much for having me.
It's fantastic to have you on. We're going to be diving into two of my big passions, two of my favorite things here, exercise and mental health. Before we do dive into some of the nitty-gritty, Oscar, I'm curious, why is the physical health of individuals with severe mental illness called a scandal?
Yeah, so it was nicely coined, I think, a scale of premature mortality. And I think the scandal is because there's this wicked problem in severe mental illness where a lot of people, they get treated from the neck up. If they have a severe mental illness, they've got a diagnosis of, say, schizophrenia or bipolar disorder. That's their primary health issue. And so their medical teams will treat them to manage the symptoms of their severe mental illness. Unfortunately, what we see is that the side effects of a lot of the treatment actually impacts the rest of their body. There's systemic, side effects or consequences to things like antipsychotic medications. But not only that when I say from the neck down, I'm also thinking about behaviors that improve our physical health as well. And unfortunately, a lot of people that live with severe mental illness have engaged in negative lifestyle behaviors. So it's high sedentary behavior, low levels of actual physical activity participation, high levels of discretionary or junk food intake. And there's a range of factors. And I think it's this scandal of premature mortality because there's actually, as a result of those things, a 15 to 20 year reduced life expectancy gap for people who live with a severe mental illness. And we talk about the gap to close in Australians, First Nations people, the Indigenous population. And a lot of people don't actually know that there's a similar life expectancy gap for those with severe mental illness. And as our general population life expectancy, as we're an aging population, we're getting older, the trajectory for people with severe mental illness is actually going down. So that we're seeing people living shorter lives. When I ask students and people who I speak to who aren't really familiar with this space, why do you think people are dying young? The first thing that people say is suicide. And that sort of, I think, is really an interesting point because it kind of talks to the stigma that surrounds mental illness. And although people might not mean to discriminate, but that's where a lot of people's minds go when they think about death in people with mental illness. And what we know is that suicide, and this is data from large, over a million individuals in UK Biobank data, they found that really 5% of the premature causes of death were suicide related. And overwhelmingly, there's about 2/3 were modifiable cardiovascular, metabolic, and respiratory conditions were the primary cause of death. So this is what the scandal is referred to, where there's this kind of misunderstanding as to why people are living shorter lives, and that actually there are modifiable factors, things that health professionals can actually intervene and improve on to try and reduce those life expectancy gaps.
That's really interesting as well, comparing it to the health inequalities of First Nations people. I'm curious, why do you think then that obviously receives so much attention, at least here in Australia, that particular health inequality gap? Why do you feel like this health inequality gap between people with severe mental illness and the general population receives comparatively little attention, at least in the general population?
I think our understanding of how big of a problem it was is actually only quite recent, like maybe only the last 20 years or 25 years. Maybe there'd been more anecdotal understandings of it prior to that. But the research around this has become much more strong only more recently. I think the other problem is that there's underlying inequities with severe mental illness because of the stigma that's associated with it. I think because it's such mental illness or severe mental illness like schizophrenia, hearing voices, it's such a stigmatized characteristic in society that it's often overlooked as a problem that should be prioritized and funding should be allocated. It's kind of like we often think about with funding to mental health or severe mental illness research, and even how the hospitals are set up, is that mental illness is kind of like the ugly cousin that no one really wants to work with or talk to because it's so complex and it's a challenging environment to work in, and it's a hard journey for patients. So I think maybe the stigma is a big part of it, but also another issue for people with mental illness, and this is part on the systems and how they need to change, is that people with mental illness aren't seeking help as often or as readily as the general population. So these barriers to help seeking that exist mean that a lot of people actually go undiagnosed or undetected with their physical health conditions much longer than someone without a severe mental illness might very readily just be able to leave the house when they notice that they're becoming unwell. People with severe mental illness might not do that as easily. They talk about in mental illness that this idea of diagnostic overshadowing, and I can provide an example of diagnostic overshadowing from when I was practicing in clinic. So I was seeing this man who was about 63. He was living with a severe mental illness. He was an incredible human. He spoke 5 different languages. He was a migrant from the Philippines, but managed to speak. He spoke Greek, and he had all these incredible strengths. His English literacy wasn't great, but he spoke so many different languages, and he had a great sense of humor. He was fantastic. And he came in to see me. He was referred to me for supporting with weight management, which is one of the most common things that people get referred to for an exercise physiologist for. But really, what was quite surprising was when I went to take his weight and his waist circumference and do all those kind of metabolic measures that I normally do, I noticed that there was some blood around the cuff of his jeans when we take his shoes and socks off. And it kind of took me back, and I noticed it was actually on both cuffs on his left and right leg, and it kind of surprised me. And I asked him if he knew what was going on, and he said no, he wasn't aware that was actually there. This is a man who's living in 24-hour care in a residential facility and was referred to me. And what it turned out is that he'd had what's called peripheral neuropathy and microvascular degeneration. So a lot of his peripheral nerves had been basically degenerating, and so were the vessels that would supply those extremities. Because he had diabetes and it just wasn't being controlled well, so his insulin and blood glucose levels were all over the place. So his mental health symptoms were being well looked after because he was in a residential facility for treatment of his mental illness, but they completely neglected what was happening from the neck down with his diabetes, and it wasn't managed, and it resulted, like, later stages for someone in that sort of presentation is sort of lower limb amputation. So thankfully we were able to catch it early, and he was able to, regulate his blood sugar levels better, and they were monitoring it better. But that's just an example of, if you have a mental illness, we'll treat you for your symptoms and we won't think about what's happening in the rest of the body. And we might talk about later what's changed, because it is getting better with a lot of this new research and advocacy from some great psychiatrists and general practitioners and other health professionals globally. But there is a movement away from that, but it is still a massive problem.
Yeah, it sounds like it speaks as well to the treatment of silos. I know, we were speaking before that as a psychologist, I get barely any training on physical health, if you like, or physical diseases, despite the overlap and the correlations between that and the mental illness. And I'm not sure what it's like from an exercise physiologist or a physio point of view, but I can imagine it's similar except flipped, where they may not have an understanding of the mental illnesses that play out with some of the patients that they're treating. So having people with silos of knowledge not understanding the overlap and correlations can cause a problem, which sounds like manifested in your patient there.
Yeah, absolutely. I think with chronic disease generally and with mental illness, and when we talk about things like chronic pain, I think there's a gradual emergence of knowledge. We're all starting to be on the same page that there's no one treatment approach that's going to work. There's this, we can talk about the biopsychosocial model of care, that you really need multiple angles into how you treat a problem, because they completely overlap. And there's now sort of more biological explanations for a lot of these, thinking about things like the HBA axis and the gut microbiome. There's all this really interesting stuff that's coming out, that we actually know that our physical health and our mental health and our social well-being, all these things are completely interrelated, and just one approach isn't going to work. And so, yeah, like you said, I think there's great scope for mental health professionals to be well trained in physical health care. Similarly, there's a great movement in physical health. I call them physical health professionals, but people like exercise physiologists, physiotherapists, dietitians, to be better trained in understanding mental illness and some of the side effects and some of the symptoms that people experience, and how to work with them in a way that's, I guess, person-centered and recovery-oriented and strengths-based, all the things that you learn in mental health training programs. We really need to integrate that across both professions.
Yeah, okay. I'm definitely keen to dive into that, because obviously you're doing a lot of work in terms of training the next generation of exercise physiologists. So that's exciting to see that it is changing. But before we get to that, you also alluded to something earlier, Oscar, about cardiorespiratory fitness and this mortality gap. And I think you mentioned something about medication as well. Can you explain a little bit about the relationship between those three things? So how do the side effects of medication play out to the mortality gap? Whether it's through reduced fitness or through the lifestyle behaviors you were talking about. Can you just kind of color that in, that relationship?
Yeah, and I'll caveat that by saying, I guess, medication is extremely important for people's treatment and their recovery. There's a lot of the clients that I've worked with, their lives have completely changed as a result of being prescribed medication, because if we can alleviate symptoms that make people unwell, and symptoms that can be often quite debilitating, if we're talking about severe mental illness, people with, well, for any mental illness really, but people I worked with in psychiatric facilities were actively experiencing auditory hallucinations. They were tormented by paranoid beliefs. When they were started on medication, it changed that. And it led to significant improvements, and they were able to have more functional capacity, I guess. They were able to work more well on their recovery goals and be more conscious of where they were in the world and how they could, help themselves. So medication is important. Unfortunately, a side effect of a lot of, in particular, antipsychotic medication is that weight gain happens really rapidly. And not only weight gain, but we see metabolic disturbances. So changes in things like our cholesterol levels, our blood sugar levels, triglycerides. We know that when these sort of metabolic markers increase, it puts us at increased risk of conditions like diabetes, cardiovascular disease, and all the secondary complications that come with that. So the weight gain is rapid. It's been compared to the weight gain that we see in the first trimester of pregnancy. So people are gaining around 12 kilos within 3 months on particular medications. Olanzapine and clozapine are some of the ones that have a greater weight gain potential. Clozapine is one that needs to be prescribed after people have at least trialed 2 other antipsychotic medications, whereas olanzapine, unfortunately, is very readily prescribed in a lot of psychiatric facilities because it has great sedative effects. So if someone comes in and they're quite manic or really preoccupied with their thoughts and quite agitated, that people will give olanzapine quite quickly. But unfortunately, then the weight gain comes. So there's a direct effect of the medication on physical health, but then medication to treat psychiatric symptoms has other effects on behavior that don't really help in supporting physical health either. So one of the side effects is people get quite sedated. They sleep for upwards of 12 hours at times. So they're really sedentary. They're not engaging in much physical activity in it or high intensity movement. And it's really hard to initiate that movement. Some patients have spoken to me about it and they're just like, Oscar, I can't. Like, I know it's good for me and I know I want to, but I'm so tired in the mornings. I just can't get myself up. It feels like there's bricks on my ankles and I'm dragging myself just to get out of bed. So there's the sedative effects, but also if you can imagine when people are tired, they're looking for quick injections of energy. And so they seek high energy or high energy dense foods. So high caloric foods, things that also give us a bit of a dopamine hit, things like a Macca's burger or a high sugar treat, things that are very high in caffeine as well. I remember doing some exercise sessions on the psychiatric facilities, the amount of coffee that people drink, just that there's a lot of, mixed coffee, just pre-made coffee where you can dilute it. And people would drink so much caffeine just to try and almost self-medicate to get themselves up and moving, and also just to give them a bit of a mood boost, I think, as well. So there's all those issues with sedation and hunger and cravings that have a secondary effect. But interestingly, there's some interesting research that even people who are medication naive but have underlying mental illnesses also have some cardiometabolic risk factors and are at greater risk of certain physical health issues as well. So medication is a big driver of this, but there's actually factors that relate to the mental health beforehand that that might be predisposing people to physical health issues.
Yeah, certainly some of the side effects you're referring to there also seem to have a similarity to some of the core symptoms of severe mental illness, whether it's depression or schizophrenia. People with moderate, severe depression might struggle to even have a shower or to leave their house, let alone go for a walk or go to the gym and engage in some of these healthier lifestyle behaviors. Or, if you're having disordered thinking all day long or having, really severe hallucinations, it can be really disorienting and really reduce any motivation to want to, again, leave the house, let alone go to the gym. Right, so there's a lot of these.
That was just a huge deterrent for some of our clients who might be experiencing, all sorts of social anxiety. So the idea of just like, oh, you should join a sports team is so unattainable for some people, or for some people who, like you said, the evolution or the depression or the anhedonia, any of these symptoms that we know are negative symptoms of schizophrenia or other mental health conditions as well. They're complete barriers in themselves. So it's elements of the condition, which is why it's this sort of wicked problem. Is we need medication to help people, but we need early lifestyle intervention paired with that. To really support in preventing those side effects. And that's sort of where we're moving to, is if we're prescribing medication, we also have this responsibility to make sure that there's a better management of their physical health right from the start.
You mentioned something as well there, Oscar, about increases in things like triglycerides. Does these poor kind of markers of health, do they occur separate to the weight gain, or are they a byproduct of the weight gain, the central abdominal obesity that happens as a side effect of the medication, or is there something direct from the medication?
It's a really good question, and I think some of that research is still developing. It's still unknown, but I have heard some really interesting studies where there's sort of small case studies where people have been prescribed certain antipsychotic medications, and they see almost overnight or over a few days changes in cholesterol levels, or increases, I should say, in cholesterol levels and blood sugar levels before we see actually any weight gain. However, in saying that, we know very clearly, and the research is very clear, that if someone has increased what's called central obesity, so that's where there's a lot of weight that's sort of distributed around the waist, you might know it better as a beer belly. Unfortunately, we see the weight that comes on from medication, unfortunately, distributes very much so around the waist, quite central. And it's that fat, it's that type of fat that surrounds the organs that's very metabolically active. So that's where it's people who have a lot of weight around the belly, around the abdomen, that we know is a huge driver. It's got a lot of inflammatory markers and leads to all sorts of things related to the metabolic and cardiovascular diseases that we see. So there could be, like you say, direct effects of the medication, which sort of the mechanisms are still sort of being understood with that. But then we know that once people are gaining weight, that absolutely there's metabolic effects around that. We touched on fitness earlier, and I guess we'll focus a little bit on physical activity as we move on. But if we talk about someone's function and their, say their global functioning, their ability to engage with the world around them. So if we can improve someone's fitness, we know that not only can we improve their function, but we can actually improve cardiovascular risk. So someone who might be a bigger body, who's overweight and does have that weight distributed around the waist, but they have a high cardiorespiratory fitness. So they could, just to put it simply, could run longer, could run faster, further, or, sustain swimming for a longer period of time, or, engage in sport and get their steps up and score more goals, however you want to measure it, not get out of breath when they're walking up the stairs. They're at lower risk of cardiovascular disease than someone of a similar body shape or weight that isn't got the same level of fitness. So fitness is a good independent risk factor that we should be looking at measuring. So in clinic, we often do, they're called submaximal tests. So it's where we get people on, say, like an exercise bike, and we ask them to pedal for 6 minutes, and we measure their heart rate's response to the exercise. And we can do those sorts of submaximal testing to understand what someone's cardiovascular fitness is, or the term is VO2 max, so volume of oxygen consumption. You might have heard that when we talk about athletes and sports performance and stuff, but it's actually an outcome that's quite useful in the clinical setting as well, because we know so much now that fitness is actually a great indicator of our cardiovascular health. If our fitness is higher, we're going to live longer and have good, strong heart muscles and blood vessels. So we tend to look at that. Similarly, and what we know is that aerobic exercise can improve fitness. Similarly, strength training is actually becoming more and more important in terms of our metabolic health. I know we're moving into now the benefits of exercise, but just to touch on it, that strength training has really potent effects on our metabolic system. When our muscles are stronger and not necessarily bigger, but when we're utilizing our muscles more, that we actually absorb better all of those blood sugars from the blood that circulate around the bloodstream. And we process our food in a much more efficient way. So we're actually doing great things for our metabolic health by incorporating strength training. And it's actually sort of written into guidelines across global health recommendations that we should be doing 2 bouts at least of strength training exercise every week. And that's sort of around 6 to 8 exercises, 10 to 12 repetitions, and using large muscle groups, which is actually really what we should all be doing.
Yeah, so you definitely touched on it there in terms of some of the benefits of exercise for these populations in curbing some of these really adverse health outcomes, the mortality gap that we alluded to. What are some of the other real benefits of exercise here, whether it's in terms of staving off side effects of medication or cognitive functioning?
Simon Rosenbaum, who is one of the world leaders in exercise and mental health. I was lucky enough to have him as a mentor and PhD supervisor, and he's a good friend. But
Nice.
I really like the way that he describes this, so I'm not taking credit for this, but he talks about the progression of physical activity and mental health research. You can kind of divide it into the role exercise plays in prevention and the role exercise has in management. And then you can talk about prevention and management of both physical health and prevention and management of mental health. So if I was to draw it out on a quad, you can talk about prevention, treatment, and mental health and physical health, because all this research is now coming out about the benefits of physical activity and movement and fitness on preventing certain mental health conditions. And I know you're going to have other academics and researchers on your podcast, people like Felipe Shook, who's doing a lot of work in depression and exercise. And there's some amazing work around that and how exercise can actually, reduce the risk of depression. There's protective factors for it. And there's some other research around this with other mental health conditions like psychosis and how we, process anxiety as well. And also then in terms of prevention, there's work that we've done actually in my previous role at the Keeping the Body and Mind program, which is just in Southeast Sydney, where we actually were able to prevent weight gain through through the medication effects. We were able to prevent that by embedding a lifestyle program that started at the same time people started antipsychotic medication. So when people took their first pill, they also came in and did an exercise session with me and spoke to a dietitian about their nutrition and joined a social sports group that we used to run within the mental health service. And we found that by integrating that physical health program, and it was physical health and lifestyle, but it was also life skills, because remember, a lot of people, when they first diagnosed with psychosis, they're generally, 14 to 25. Generally. So they're learning all the life skills to be independent and teaching them important things like how to structure your day and how to, use cooking equipment and how to read food labels. All these things are so important for our physical health, but we often take them for granted. And if you're not getting the right sort of training and support around that. So we really made sure Keeping the Body Mind was a lifestyle and life skills program. But to come back to your original question, yes, there's evidence that if you embed lifestyle interventions using physical activity and nutrition, that we can prevent the weight gain. Another key thing there is smoking cessation. We can't factor about how important cigarette smoking or tobacco smoking is. It's highly prevalent among people with severe mental illness, about 6 times. I've read some interesting statistic. I think it's around 80, don't quote me on this, but there was something like 80% of the cigarettes that are smoked today are smoked by people with a severe mental illness. So this is in Australia. So I'll find the data that maybe you could share to that under the link. But generally what that data was saying is that there's a downward trajectory of cigarette smoke or tobacco smoking in the general population. But people with mental illness, there's no change. We're still seeing really high amounts of smoking. So exercise works from a physical health preventative point of view, and there's this evidence around it being preventative or protective for some mental health conditions. And then the stuff that we know very well, and where all the large meta-analyses are coming out now about the beneficial effects of exercise on symptoms. So if we think about mental health symptoms, we know that exercise can improve psychiatric symptoms. So if we look in psychosis, it can improve positive and negative symptoms. But there's also a lot of work that's been done on the comorbid symptoms of conditions like psychosis and high rates of depression and anxiety, and that can be improved through exercise as well. So then you mentioned the cognitive symptoms. So there's all this great work. Dr. Joe Firth in Manchester is a big driver of the cognitive effects of exercise. I highly recommend people look into some of his work. He's done both sort of randomized trials, but also then gathered all that evidence from meta-analyses and shown that exercise has great effects on cognition, which we know is also an issue. Cognitive decline or cognitive symptoms in people with severe mental illness is a big issue. So exercise can have an effect there as well. Simon's work on exercise in trauma, he's been going into refugee communities in Bangladesh, at Cox's Bazar, where they're talking about some of the populations who are most exposed to trauma, and exercise is one of their key outlets. It's one of the things that helps them manage what they refer to as tension, but it's their word to describe the stress and trauma that they experience on a daily basis. So there's all these beneficial effects of exercise, both on a local and global level. And then, like we touched on briefly, the physical health disparities in severe mental illness are so great. And exercise, we know in the general population, can improve physical health. Well, that's no different in mental illness. We can see reductions in cardiovascular risk. People improve their blood pressure, their weights, central obesity, all these great indicators. And their function improves as well, like as we said, in terms of if we improve physical activity levels. Yeah, I think, does that summarize the evidence? I hope. Yeah.
Yeah. Oh, you've done it better than I ever could, Oscar. Yeah, that's definitely a great summary. And I want to touch on the cognitive side of things, because you mentioned, I think it's Joe Firth from Manchester, and I came across one of his systematic reviews and meta-analyses showing the improvements that exercise has on cognitive functioning, but in particular social, cognition, attention, and working memory, which are particular cognitive functions that are decreased, if you like, in individuals with schizophrenia and psychotic disorders, and are also cognitive functions that are hard to target with things like antipsychotic medication. So to me, it really shows again the value that exercise can uniquely have in these populations that perhaps other therapies or other treatments can't.
Yeah, absolutely. And I think there's great promise there for interventions that combine certain treatment modalities. I know psychologists, at least the psychologists and mental health workers that I used to work with within my mental health treatment team, they used to provide cognitive remediation as a group program that they did for a lot of our young people, and that was really effective. And we looked at trying to embed exercise as part of that cognitive remediation group, so you get the beneficial effects of the exercise and then some of those more fine cognitive skills tests that you do in the room setting. So I think there's great scope for combining exercise within psychological interventions like that to address cognition as one of those factors.
Hello everyone, a quick break from today's episode. At the Mental Wellbeing College, we are committed to the goal of communicating evidence-based wellbeing strategies out to the broader community. The goal of this podcast is to bridge a gap between self-help material and peer-reviewed research by providing evidence-based discussion that respects the nuances of psychology but is digestible for all audiences. Ultimately, I hope that you as a listener feel empowered after each episode so that you can take away and implement strategies to improve your own mental well-being. If you have gained value from this episode of the Mental Wellbeing College, I would be so grateful if you were to hit subscribe or follow, or to share this episode with someone that you love. This is how we continue to grow the show, get the message out, and to impact people in need by providing such information and strategies. Thanks so much for tuning in. It means a lot to us here at the Mental Wellbeing College. And now back to today's episode. Yeah, that's so true. Certainly using it as an adjunct, certainly in I'm seeing more and more in depression in particular. A lot of like the national guidelines, the NICE guidelines in the UK, the Royal Australian New Zealand College of
Mm.
Psychiatrists, and separately the College of GPs, both recommending now exercise be used as a treatment adjunct with either antidepressants or CBT for depression. So it seems to be coming more and more to the fore and more recognized in areas where it matters as well.
Yeah, absolutely. I think that's a really good point in that where all this evidence has kind of mounted to is informing guidelines and informing practice. And as you say, it's been written into a lot of practice guidelines and treatment recommendations. And another local New South Wales based kind of example is which has been replicated on a global scale now, but some colleagues, Phil Ward, Jackie Curtis, and international colleagues of theirs in the UK, David Shears, they developed the positive cardiometabolic algorithm, which is basically a tool that helps medical professionals and other health professionals when they're prescribing antipsychotics to determine what level of cardiovascular risk someone is in based on high risk, moderate risk, and low risk, kind of like a traffic light system. And it has all the risk factors from lifestyle related factors like physical activity, nutrition, smoking. So some of those more cardiovascular or metabolic outcomes like blood sugar levels, cholesterol, blood pressure, those sorts of factors. So those sorts of things are now being embedded into New South Wales Health, practice. So we see all clinicians being provided this tool and being, recommended or encouraged to utilize it within their practice. So, yeah, there's absolutely a lot of movement towards embedding this sort of protective physical health interventions in routine care. I should just call out with, I guess, that physical activity and mental health research is that the evidence sort of, you mentioned adjunct, and which is what triggered my memory, is that physical activity, what we need to clarify is that it's not a replacement for other mental health interventions that we know work really well. And physical activity might not work for absolutely everyone. So we need to be mindful of that it is an adjunct to mental health care if we're talking about severe mental illness. If we're talking about, more mild to moderate depression and anxiety, exercise actually has been shown to be equally effective as medication. So we could be actually doing more work to use exercise as the first line treatment in mild to moderate mental health conditions. But with severe mental illness, it's not a replacement for treatment.
Yeah, yeah. No, that's an important point to make. You mentioned another important point as well that I hadn't come across before, which you said, I think it was Simon Rosenbaum was doing some work in Bangladesh and perhaps more developing countries. And this is one of the things that I really love about exercise is that it's accessible to people in a way that antidepressants, antipsychotics, psychopharmacology perhaps isn't, whether it's due to supply of that or cost. CBT, my primary tool of therapy isn't accessible in many developing countries because there's just not trained therapists there. So I see and hope that exercise is distilled in developing countries as well as a tool to use for mental illnesses. But it sounds like there's work already on that. Can you speak to that a little bit more? Because that's really intriguing.
Yeah, I guess at risk of speaking to someone else's expertise or someone else's work, I think it's not so much about. I mean, there's work to train, people that work in those sort of NGO settings within. I know Simon was talking about when he was in Cox's Bazar. There's a refugee camp there that is basically over 1 million people. I know Craig Foster, the Australian ex-Socceroo and SBS commentator, he recently went there, and you can follow his story through his Instagram just to get some visuals of what it's like. But Simon is the best person to talk to this because he was there in the flesh. But he describes it. There's huge issues around trauma and all sorts of mental health concerns, and just the living standard. Apparently, as I say, I wasn't there, but it's really hard living. Resources are very thin. But one thing that they already were doing before anyone sort of came in to talk about the benefits of exercise is that football or soccer, we call it in Australia, is huge, and it's one of the things that really builds the community glues the community together. And it's really one of the main things that people look forward to. And they've got sort of structures around their social networks and stuff that are built around football. It's one of the key things that make people feel a little bit of relief in the dire circumstances that they're in. So yeah, in terms of it being a tool for social change, I think it's extremely accessible. But in saying that, back on a local level, a lot of people don't like sport, and exercise in itself has its own stigma attached to it, in that people think that you need to, in Australia, I'm thinking in Sydney's eastern suburbs, if you're exercising, you have to dye your hair peroxide blonde and wear some lycra leggings and get a fitness first passport. But if you've got very eastern suburbs, and drink your soy latte on the way. But if you've got a severe mental illness and you're so sedated and you've gained weight, like you're a young person, you're already conscious about your body image, and then you put on this medication and you're developing a beer belly, like how deterring would that be to sign up to that kind of environment? All your friends are, skyrocketing in life, they're getting jobs and they're, fit and healthy, whereas you're sort of gone backwards. And I think we need to make physical activity also more global and more accessible in how we describe it. That, if we can actually get people from very minimal activity, from being very sedentary, just to doing very light bouts of movement. And that could just be very simple things like, walking around the block, or engaging in more what we call incidental or accidental movement. Some people might prefer to get their activity or their physical movement through things like gardening or dance or moving. And importantly, we need to think that exercise can be a few different things. Physical activity can be a few different things, and leisure time physical activity has great effects. Occupational style physical activity. So if we think about laborers, they don't get the mental health benefits as great as if it was the leisure-based physical activity. So there are different types of movement when we think about the context in how it's being performed. But we need to really encourage just a general moving more and sitting less. I think that's the real key message, and that could be any form of movement. The benefits are great, independent of what we're doing.
Yeah, very, very important. I remember a friend of mine about 5 years ago or so was diagnosed with schizophrenia, and we spent a lot of time together. We're just going for walks and things like that, and we talk about what was going on in his life. And for him, it was really demoralizing to see rapid weight gain from his antipsychotic medication. And you talk about beer belly, and that was exactly what was happening. It was all kind of going around his abdomen, and feeling, really self-conscious. And things like dating life were really difficult for him, let alone catching up with friends, and feeling humiliated. Are they judging me? And then you're trying to encourage someone, like you said, to go into a gym where you've got 20, 30 other people training at the same time, most of whom are really fit and experienced. That level of self-consciousness and anxiety can skyrocket, and in some cases it could almost be more detrimental for their mental health in those particular environments. So I love that message about making it sustainable, personalizing it, and physical activity rather than necessarily exercise in a gym. It doesn't have to be that particular modality or form.
Yeah, absolutely. And just trying to normalize it, that gyms don't have to be the only way that we exercise, and also sport as well. Like sport, there's great benefits to social sport, but not everyone likes to participate in sport. So how can we think of other ways, social ways, that we can get people moving together? One of the really well-received groups that we had for our clients in the mental health unit, particularly when they were at the 50 to 60 age group, was we just did walking groups and walking photography. So we would use photography as the kind of catalyst. There were more creative minds, people who were less focused on exercise and more into the arts. And we used photography as the incentive, but we would go out and just do a walking group and take photos, have a theme of photography that we would do. And incidentally, I think it was actually kind of mindfulness as well, because if you're just looking for, say, green objects, you're really just focusing on your environment and your surroundings, and you're feeling quite present. But then we would be walking, incidentally, like we'd be getting, 2,000 to 3,000 steps up, and people would come back and we'd talk about, did you know that you actually achieved much more than what you've done lately? And they were surprised. They were just thinking about what they were doing with their photography. So yeah, absolutely. We need to think about how we can embed movement in everyday life and make it tailored to people's interests. Like, what do they love? What are their key things? Yeah.
So this notion of gardening, sports teams, photography and walking while you're doing that, or going to the gym, just different forms of exercise to make it sustainable for the person. This is really touching on a really key kind of predictor of exercise adherence amongst people with severe mental illness that I see in the literature, which is autonomous motivation. Can you speak to a little bit about the importance of that?
Yeah, absolutely. So according to the self-determination theory, there's different types of motivation where we have, our more autonomous motivation, like you say, and that's kind of more intrinsic. So we're wanting to make changes for ourselves. So if we use exercise as the example, I want to exercise because it makes me feel good. Like it's genuinely something I look forward to in the day. I really want, it's something I use as a bit of like a break from my busy world, and I really look forward to it. I'm very intrinsically motivated and autonomous in my choice in how I do it. To more extrinsic forms of motivation, which is probably quite adjacent to what the traditional medical models were, where a doctor or a social worker or a psychologist would tell the patient or the client what they need to do to make themselves better. So what we know now is that that's more extrinsic, or it's more external to the internal motivator. And so what we really need to try and do is support people to get along that chain of motivation. So get them from thinking about healthy lifestyle behaviors like exercise that are quite extrinsic to making them want it for themselves, essentially. But what we know is when people are more intrinsically motivated, that they absolutely are more likely to sustain behaviors. And a lot of motivational interviewing, which kind of was developed around, I think it was around 30 to 40 years ago, but earlier than that, but it became much more used with smoking cessation and drug and alcohol abstinence programs. And then it sort of as integrated to or translated into a range of different lifestyle benefits. So using motivational interviewing, which is a process, it's sort of like a form of counseling. I'm sure a lot of your listeners will be very aware with motivational interviewing, but we definitely use motivational interviewing in practice to help people with lifestyle behaviors so that they don't rely on coming to see us as the motivator, that they're also active outside of that, because their 2 visits in a week or 1 visit in a week isn't enough to get the benefits of exercise. They need to be active on a daily basis, need to make exercise a routine habit. So yeah, motivation is absolutely a key thing, and autonomous motivation, giving people choice. I'm sure you guys are all across is it the 3 psychological needs, the competency, autonomy, and relatedness. Yeah. So it just falls into those 3 elements where we need to integrate exercise into those 3 needs. So by making it autonomous, people have choice over what they do. They could, choose things that are, more of interest to them, that is aligned with their needs and their goals. If it's relatable, then it's or relatedness, then it could potentially be in a social environment, or it could be things that they're more familiar with. So activities they used to do when they were young. And then if it's competence, we need to make sure that we're suggesting exercise or promoting movement that's at a level for people's fitness capacity or their ability level. If we're chucking people in the deep end or signing people up to a sports team that's way too advanced to them, that's not going to be very good for people's motivation. They're just going to get disheartened by that. Similarly, if it's too easy, and that you're putting them into an exercise program that's too easy, they're going to lose motivation very quickly as well. So we need to kind of tailor it according to those psychological needs.
No, this is so important. And I see a theme here, which is that we've been talking about, which is that there's many ways to kind of skin a cat, as the saying goes, and that, like you've mentioned a couple of times, you don't need to throw someone in a gym to get them to have these benefits that you've talked about today, but it's about finding the most personalized and personally sticky and sustainable way for them, and working with the client or patient to find what is the way to get you moving more that's going to be sustainable, work the best, intrinsically enjoyable in the moment for you. And that's going to look very different from you, Oscar, to me, Indy, to people listening. It's different for each person, and finding that way for the individual.
Absolutely. And I remember, so I was trained as an exercise physiologist. And I remember within the first year of working, I feel like majority of my sessions with one of my clients became just closing the door with me, myself, a student, and another client. And we put the music on and we just dance and improvise dance, because this is a young person who was, I think, 18, a big Taylor Swift, a T-Swiftie fan. And she was really struggling with getting to the idea of doing like a structured exercise program, like a strength and aerobic session, getting on the bike. She was just not motivated by that, and kind of just didn't want to be there. And so I put some music on, and as the clinician, just started acting like a bit of a clown and started dancing. And she found that very funny. Not because my dance moves were bad or anything; they're really good. It's just she was surprised, I think, more than anything.
Of course not.
But she started dancing with around the clinic as well, and we just got into it and started doing a dance session, and then we started choreographing different dance exercises together. And
Nice.
I wouldn't have thought in my undergraduate training that this is sort of what I'd be doing in a professional setting, but this is what we've got to do. Is we've got to make movement accessible, make it fun, and make it enjoyable, and that's what will make it most sustainable.
Yeah.
So I think that was a really nice example of what exercise can be. And not only that, it's a really big point is that person really had poor engagement with the mental health treatment service as a whole. They weren't attending their psychology sessions. They weren't really keen to come and talk to the psychiatrist about medications that they didn't want to take. But they were willing to come and dance with me in the clinic. So the whole mental health team saw that as a bit of like a soft entrance into the mental health treatment. I was kind of the bait almost to the mental health service, which is a big thing, is why I promote exercise physiology as it being a really integral part of a mental health team, because it can be one of the sort of therapeutic engagement opportunities to really support people. Like other anecdotes of a lot of men who, previous fitness people, weightlifters, developed mental illness, became really unwell, unfit, but they still like sport, and they didn't like to talk to their psychiatrist. They didn't like to. A lot of men typically, I don't know if you find this in practice, but men struggle with their emotional intelligence and being able to communicate their feelings. But not all men, but a lot of the men, that stoic archetype. But they would come and they'd throw a footy with me in the park. And that actually opened up a lot of conversation about their mental health, which then I was like, this is actually really important stuff that you talk to the treatment team about. Would you be open to talking? And it was a way of breaking down barriers, I found. There's some great programs that happen in the community, and a shout out to a friend of mine, Joel Pilgrim, who started an organization called Ways of Wellness. And it was built on the back of a social stigma self-sustaining community called One Wave Is All It Takes, which is Grant Treblecko and Joel Pilgrim and some other of their friends put it together. But they meet every Friday at Bondi Beach. They dress in fluoro from about 6:45 a.m. and go swimming and surfing. But they also sit down and have a chat about mental health. And they wear fluoro because, if you see a bunch of people standing down at the beach at that time in the morning wearing fluoro, you're asking, what are they doing? Well, they're trying to start a conversation about mental health. So doing that in the guise of a socially cool activity like surfing, I thought was a really nice way of breaking down the stigma with mental health and really talked about the integration of physical and mental health as well, right? Because they're using surfing as the bait or exercise as the relatable thing, but then talking about a really important and taboo kind of topic being mental health. So yeah, I think exercise should not only be considered a therapeutic intervention, but also a way to build therapeutic engagement in programs.
Yeah, love it, love it. From dancing to Taylor Swift in a clinic with your exercise physiologist to talking on the beach after a surf on Bondi Beach in fluoro outfits. Many ways to skin a cat. I think that certainly sums that one up. Speaking to a lot of my colleagues, fellow psychologists, the consensus seems to be that they are aware of the general benefits of exercise for mental health, perhaps not to the level of depth that you've taken us through today, but general benefits definitely aware of. But there's a reluctance to actually implement that and use that in therapy for a couple of reasons. Number one is, do I, staying in my own lane, do I need to refer to an AEP, accredited exercise physiologist? If so, how do I do that? And then also it's about not having the deep understanding as to what are the moderators, what intensity do I need to prescribe them at? What, duration do they need to do? Should it be aerobic? Should it be resistance training, all the kind of the finer details. So without necessarily, canvassing all the moderators of, effective exercise for mental illness, what kind of advice would you shed for the many psychologists or students listening who would fall into that category of, I've got that general knowledge, but I'm scared to use it as a therapeutic modality or as a treatment, because what happens if I need to go deeper into that and I don't have that knowledge?
Yeah, that's a really good question. A really practical question, and some of the work that we're doing is really trying to build the confidence, the skills, and the knowledge of other health professionals so that they can be, I guess, social prescribers of healthy lifestyle, not just exercise, but also healthy nutrition and smoking cessation. Psychologists, just for example, like a lot of your listeners are very well placed to do this because you've got the skills in behavior change through your CBT principles and motivational interviewing and behavior change counseling. So you're very well placed to do this. Being scared of what exercises to sort of suggest or recommend, I think, is a common thought. And I think there's a few things that come to mind there. We've got our general recommendations, like our physical activity guidelines, which is 30 minutes of moderate to vigorous physical activity most days a week, so 5 days a week, trying to accumulate about 150 minutes, and then doing aerobic exercise 5 days a week and 2 bouts of strength training exercise. That's what our guidelines are. However, for a lot of people, that's not attainable. And like we've spoken about this whole podcast, is that it needs to be tailored to the individual needs. Is that, like, if, a strength training session in the gym isn't the best thing for a lot of people. And, going on a run is also not accessible for a lot of people. So how can we make it more person-centered, I think, is the thing. And a psychologist could sit down with their client and ask them, to get moving, what do you like to do? Like, what are some things you've done in the past? What really brings you joy? How can we build on that? And it might just be going from a little bit of change to then gradually progressing. I think if any principle I'd try and communicate to your listeners is that start low and go slow. And then if any health conditions are there, like if there's any comorbid metabolic or pain or any, musculoskeletal issues or anything like that, maybe that's when an exercise physiology, a different professional is really warranted to come on board there. But in terms of supporting in behavior change, that really could be a job for a psychologist or other mental health worker to kind of support with. And it might just be about setting really small and attainable goals. So if it's physical activity, it could just be increasing the daily step count by, 300 steps. So maybe doing one walk around the block if this is someone who's like bedridden, really can't get out of the house. But understanding where someone's at and how we can slowly progress them towards meeting those guidelines in a way that's tailored to them, I think is sort of the general recommendation. What we know with the evidence is that there's a dose-response relationship. So the more that people do, the better effect that it has both on physical and mental health. But there's no point just giving people the guidelines if they're extremely sedentary, because like we say, that's not hitting those competency, autonomy, relatedness. It's not going to be motivating. So we need to start low and slowly progressively build our way up. Does that answer your question? I'm sure there's other things that might come to mind.
Yeah, no, it does. And I think in a really nice soundbitey way, gives a philosophy for psychologists and students listening, start low and go slow, a philosophy for them to kind of implement and go forward with. So definitely does, Oscar. Thank you. And thanks so much for coming on and for sharing all your wisdom. Reading through your research was a really cool experience. Exercise in particularly psychotic related disorders and schizophrenia wasn't a literature I was really familiar with, but it's been a cool experience to read through your work in that space and talk to you today.
Thanks, Indy, and you're helping sharing the good word. So appreciate you inviting me onto your program. And if any of the listeners want to reach out, please feel free. I'll provide my Twitter and contact details so that they can get in touch.
Thanks so much for tuning in to today's episode of the Mental Wellbeing College. If you've made it this far, it means you've either gleaned a ton of value from today's episode or you've fallen asleep. I sincerely hope that it's the former, and if it is, I would be so grateful if you were to hit subscribe, follow, or to share this podcast with someone you care about. Our mission here at the Mental Wellbeing College is to provide a free and accessible resource for people to take action and implement to improve their own mental well-being. And you subscribing, following, and or sharing helps us to achieve that mission and to impact people in need. Thanks so much for tuning in. It means a lot. We'll see you next week on the Mental Wellbeing College.